Our next speaker is Dr. Kotwicki, who is going to tell us about a successful intervention.
Yes, thank you. Good day. Foremost, I want to thank the forum for convening this important dialogue and including me. And I am delighted to talk with you a little bit about some education and treatment opportunities that are really a viable alternative for incarceration for people with mental illnesses. As we've talked about before, I want to spend a little bit of time discussing the role of stigma, but particularly stigma in first responders. And I'm going to define first responders not only as law enforcement agents and other people in the community on the front line, but really working with primary care doctors and people who are learning how to provide medicine, medical care and interventions. And one of the things that we have used successfully at Emory University, where I have taught, is an intervention that is a 4-year program for medical students to help people identify patients in primary care clinics and other places that do have symptoms of mental illness, who have impulsivity, who may be acting out in a parasuicidal way in order to communicate important ideas, and how we can try to shunt people away from the penal justice system and toward treatment. Once people agree to treatment, though, there have to be good places for them to go. I'm Chief Medical Officer at an innovative program called Skyland Trail, and probably the most important thing that I'd like to share with you over the next 13 minutes is a video of one of our patients who was at risk for violence, who was at risk for being incarcerated, who came to treatment and had a successful recovery. And so really I wanted mostly to introduce you to Victoria in a little bit. First, I also would like to talk a little bit about some of the outcomes that we do. Our patients do periodic assessments of things like anxiety, impulsivity, side effects of medications like akathisia even become terribly important in understanding how to decrease somebody's risk for violence. And I'll share some of the outcome data for you in people who go through our recovery program. Like all good trained psychodynamic psychiatrists, I needed to start off with exploring my conflicts with you. But instead of making it a negative thing, I want to make it sort of an advertisement, which is that Dr. Michael Compton and I wrote a book called Responding to Individuals with Mental Illnesses. And it's actually been used to train over 12,000 police officers across the country in crisis intervention teams that Shelley was mentioning. Please don't feel compelled to use our book, but I think if locally we can champion the idea that helping law enforcement officers identify people who may be misbehaving or breaking the law because of mental illnesses rather than malice, and helping those people get treatment rather than incarceration is a very noble cause. So one of the things that the medical students have told me again and again is that they don't think psychiatry is really a good option for them as a medical specialty. In fact, my mother the other day said, "Oh, honey, I thought you were smart enough to go into an actual medical profession, not psychology." And I said, "Well, Mom, no, I'm a psychiatrist, but I think we have to really make sure that we understand that people who are passionate, who are intelligent, who really want to change the world and focus on social justice should be compelled to go into psychiatry. I can't think of a better career option." And one of the things that the medical students like to learn is the physical origin of mental illnesses. We have many new good data that mental illnesses like depression or schizophrenia have biologic etiologies. We know that as a group overall, people with major depressive disorder have aberrations in their immune system. They have increased levels of interleukin-2 and interleukin-6, as well as tissue necrosis factor alpha. And to be able to link the physiology behind mental illnesses in some ways legitimizes the sense that people cannot just think themselves better if they have a mental illness. We also know that people in medical school who go into clerkships, who are forced to go do a psychiatry clerkship, for example, in a facility where recovery is not the goal, but containment is the goal, tend to have a much less positive experience in working with individuals who have mental illnesses. So for all of those reasons, we really want to change the paradigm in which we attract people to go into mental health professions, in which we inspire people to try to shift the locus of mental health containment away from jails to appropriate treatment. So in addition to thinking about how to make access more likely, one of the other things that we focus on from an outcome perspective is that recovery work is probably one of the best ways to convince people to participate and to engage in treatment rather than going to jail or having some kind of coerced treatment. Recovery work is not only based on reduction of symptoms, it's based on quality of living, relationships, functionality, and we really use the patient's own recovery goal as the undergirding principle that drives all the other interventions. This is a really fun way to help people do as well as they possibly can. It's not just thinking about limiting people, but helping people expand to do the best that they're capable of doing. So thinking about education, crisis intervention teams training is an important strategy for first responders like law enforcement officers. We did a little study which was a paired sample pre-test, post-test study looking at law enforcement officers' attitudes as well as knowledge based on working with people, in this case, the study up here, who had schizophrenia. And what we found was that over a 2-day course, working with people from the mental health services industry, working with psychiatrists, working with nurses, and even primary care doctors talking about the inextricable link between mental and physical health, law enforcement officers who went to that training had a very robust, statistically significant improvement in both their attitudes and their knowledge about what to do when you're encountering somebody in the community who's misbehaving perhaps because of symptoms of a mental illness. We also know from other research from people who've published in academic psychiatry that being exposed personally to an individual who has mental illness is probably one of the best ways to reduce our personal stigmas about what people who have mental illness are like. And that's why I wanted to bring to you today a video in just a second, of one of our patients named Victoria. And the reason that I picked this is because Victoria was at risk for incarceration. She also really continues to like doing things that are aggressive. She's a kickboxer. And this is an example, hopefully, of the power of recovery and shifting the paradigm so that we can help her make the most of her life. Could you play the video, please?
I tried a lot of different coping skills to help me. They were negative, some of them yes. I tried to help myself and self-medicate by using drugs, and then that didn't help. So I moved on to self-harming. I've been to a lot of therapists. I've been to a lot of psychiatrists. I tried hypnosis. I tried acupuncture. I had ECT. I tried any and everything I could think of. I did neurofeedback. My life was miserable. I was living in hell every single day. Coming into Skyland Trail, I didn't trust anybody. I didn't know what a healthy relationship was. After a while of being at Skyland Trail, I started to have that hope again. I had the clients I could relate to. I had an amazing therapist. I had a psychiatrist that told me what I was diagnosed with, and I had no idea I was diagnosed with borderline personality disorder and PTSD. And it gave me hope when I started to understand DBT and when I started to apply it, and it was incredible how it worked and how it decreased my emotions. And I'm so grateful for Skyland Trail. They're my family. Skyland Trail is my family, and they will always be my family. I just have this brighter outlook on life, and I want to become a therapist, and I want to help others as they help me. And even though I'm working toward certain things, such as being a therapist, I'm just excited with the path that I'm on. People who don't believe that people with mental illness can get better, I'm proof. Age 10, I've been suffering with mental illness. And with hard work, dedication, and willingness, it is possible. It is very possible.
Thank you to Victoria for giving me permission to share her story. Oops, could you go to the next slide, please, Audrey? Thank you very much. So We measure periodic indicators that are associated with violence in people who have mental illnesses. And I think that we've covered some of the research data about psychosis and impulsivity, the lack of community, really thinking from a recovery model about helping people cultivate communities that truly care about one another and can be there to support one another might be the key to some of the prevention things that we're talking about. And then some of the World Health Organization immediate environment factors that also make people act perhaps impulsively or desperately. And in the, again, paired sample pre-test, post-test outcome assessments for people who come to a recovery program, what we have shown is that people get very statistically and clinically significantly better. On the BASIS 32, which is sort of the gold standard outcome assessment that ambulatory behavioral health care centers use. What I hope you can see on the graphs up here is that between the time of admission and discharge, people who go to the recovery program have a huge improvement in their psychotic symptoms, in their impulsivity symptoms, and also in their brief psychiatric rating scale for people who are diagnosed with schizoaffective disorder or schizophrenia. And so we understand and assume that these important improvements, not only in the symptomatology, but that in social relationships and the quality of life scale data, it makes people much less vulnerable to having to figure out how to have their needs and their desires met through ways that might produce violence or through other impulsive behaviors. So I hope that you can trust the data that if people can be shunted to treatment rather than incarceration, that once there are good treatment facilities that are available, that recovery is indeed a possible thing for folks who have mental illnesses. So conclusion, medical illnesses are medical problems. Mental illnesses are medical problems. And I think if we can remember that, it's not volitional. You can't think yourself better. You can't decide to do something differently if you're experiencing symptoms, but that treatment is really quite good if you can access it. Recovery possible, but access, I think, is the rate limiting step. So please help everybody get to treatment who has a mental illness, and thank you for all the good work that you do. Now I'm there.